Hi everyone. Today we are going to discuss about how do we prepare for a telephone encounter to report a change of condition. This is a very important topic because in this topic we are going to learn, for example, if there is any change of condition before we wanted to start to do telephone encounter, how should we prepare, what kind of information we need to put on together. Now in the next weeks, I'm going to go symptom by symptoms and technically teach you what kind of information you need to collect. For example, if you are doing respiratory symptoms, what are the symptoms you need to collect? If you're, for example, having a patient with pain, if you have a patient with abdominal pain, what kind of information you need to collect from the bedside in order to do this. The next things that we need to learn is about what is going on that we are going to learn today. First of all, how do we prepare for a telephone encounter as we discussed? What are the elements and information we need to collect before the call? And how to present the change of condition, which we're going to work more in the next sessions. The principle of the good communication is always based on one thing: collecting critical information. I believe for every nurse on the floor, before you want to do anything, it is very crucial to know what is the critical information I need to collect. And it's very important because this information should be systematic and also in the timely fashion. And AMDA, or American Medical Directorship Association, has a very good data collection series before to call Use Know It All Before You Call. I highly recommend for everyone to look at it. It's actually very useful information that based on Interact and can tell you symptom by symptoms, but we were going to discuss about every single symptoms in the next sessions. Never and never and never think and assume that the physician over the phone knows the patient very well and can remember all the relevant details. Almost impossible. Most of the physicians have many cases in the different nursing home. They really don't know about patient. Don't think that the physicians are aware of the patient. For example, if you're calling a physician at 2 o'clock in the morning, don't think the physician even know that this patient is for example, Mr. X or Mrs. Y, and this is the medical history they have. They don't. They do not. If you're calling for after hour, for most of the institute, they have the after hour system. Don't think that they have any idea that who's the patient is and what is the relevant information. You actually know more than them about the patient. For example, don't think that the physician know that what was the previous lab result, or even you think that the physician know the current medication list. I wanted to tell you, answer is absolutely not. They really don't know. And you're the one with having the charts in front of you and preparing your physician. You can help them to understand what is the medical condition, what are the medication is on, what the medication has been changed recently, what are the labs has been changed. These are the information that you need to know. The principle of the successful telephone encounter is based on first information, who the patient is. That's the number one. The resident name, that's very important. A lot of time physician asks you over the phone and said, who's the patient? Is this my patient or is this belong to somebody else? Is it the patient for us or a Kaiser or another HMO system? You need to really say the name of the patient and make sure this is the right physician that you call. It's not a wrong physician that after like 10 minutes of conversation, finally say, oh, by the way, this is not my patient. That's not a good, successful telephone encounter. Is this the right patient? Is this the right physician? Admission date is so important. A lot of the physicians, they don't know when the patient even was admitted. This patient's been here since a week ago. This patient was admitted just last night. It's so important. And the main cause of admission in a skilled nursing home is so important. This patient came because had a history of pancreatic cancer, now is on chemotherapy, is here for rehab. This patient is a status post hip fracture. They did hemiarthroplasty in a hospital, is here for rehab. That's it. You don't need to say this patient has hypertension, high cholesterol, patient has history of the removed shoulder, broken shoulder. No, you just need to say this patient is the reason this patient came. Patient has multiple myeloma, is on infusion therapy, is weak, is here for rehab. This patient is here because of being on wound vac, because has like a productive wound. That's the main cause of the admission. The basic information, the first thing you always need to check in the chart, what is the code status of the patient? That's very, very important, because it's not appropriate that you start a conversation with the physician and say, okay, what is the code status of the patient? I don't know, doctor. Let me go check it in the chart. No, you need to prepare all this information ahead of time. Patient is full code, by the way, doctor. Patient is DNR, DNI. Which hospital this patient is coming from? What is the hospital preference? That's very, very important. Who is decision maker? Is this the self or somebody else is making decision? That's very, very critical. A lot of time the nurses comes over the phone. They don't know, is this patient responsible? I don't know, doctor. Do you know, is there somebody else thinking, making decision? You need to prepare that. No, doctor. Patient is not decision maker, has a DPOA, which his or her son or daughter or the wife or anybody else or a friend. You need to prepare for that. If something happened to the patient, we need to know who do we need to call. Sometimes the physician need to make a very important call to the family member. Who is DPOA? Who need they call? Any allergies, it's important to be prepared, because there's a possibility, for example, your patient has a urinary tract infection. The physician wants to prescribe antibiotic. I wanted to prescribe penicillin. Okay, good. What is the dose? That penicillin, 500 milligram every 6 hours. 2 minutes later, call again. Oh, I'm sorry, I just checked the chart and the patient is allergic to penicillin. That's not appropriate conversation. That's not appropriate communication. You need to know, by the way, I want to tell you the patient is allergic to sulfa, penicillin, contrast, whatever. And that's the allergy is part of your preparation for telephone encounter. Any recent lab work needs to be discussed. Any recent lab work needs to be prepared. For example, 2 days ago, we have the lab result. The hemoglobin was 10.6, which was a drop from the previous one, was 12.3, and today patient is very weak. Then the physician over the phone knows, oh, interesting. Then last week was 12.6, hemoglobin 2 days ago was 10.6, and now patient is weak. That's why it is so important to know that a patient is, it's very weak. And then the next question is symptoms and concern of the symptoms or concern. We need to focus on symptoms. What is the characteristic of the symptoms? What is the course? What is onset? What is the location? What makes it worse, aggravating factor? What makes it better, relieving factor? And what is the history? The next question is continues on that. When we're talking about characteristic, we're talking about quality and quantity. For example, we talk about quality of pain. What does it mean? Is it the sharp pain? Is it the burning pain? Is it the dull pain? Is it like knife stabbing pain? Is it needle sensation pain? This is quality. We're talking about quality of pain. What kind of quality this pain has. We need to say, don't say only pain. You say this is a sharp pain. This is a burning pain. It is important because that makes a totally differential diagnosis. More on the quality, like for example, you want to say sputum. Is this sputum is yellow, bloody, green, white? This is quality. We will talk about more based on the symptoms. But think about every symptom has a quality. Quality of vomiting. Is it contains of blood? Is it fresh blood? Is it dark blood? Is it coffee ground blood? These are the quality. You explain the symptoms. This is called quality. The other things is quantity. When you talk about quantity, you're scoring the pain. 0 to 10. You talk about this is intermittent pain or persistent pain. You're talking about the sputum. Is it a small sputum? Is it a large sputum? These are the way. Like, for example, you say, this is yellow sputum, small sputum versus large sputum. The next thing is about course. Is this symptoms is getting better since afternoon, or is just getting worse? Or is just getting a little bit better and it got worse? Since the symptoms started, it is very important to talk about change of ADLs. Is this patient able to maintain the posture, able to drink, able to eat? And how is the mental status of the patient, alert or confused? That's a critical decision, because if you have a symptoms that is changing the patients for ADLs, that means it's a very serious problem. And that's going to be a good clinical judgment. What should we do next? The onset of the symptoms. When it started? When? It was from yesterday morning. It gradually started. This morning it got worse. I got a report from the last shift. How long has it last? What type of is it the sudden or is it gradual? Is the chest pain started from yesterday, or the chest pain just started today right after patient came from the bathroom? Or the patient is very sweaty, but it's very sudden onset. And I can say from 7 p.m. till now, I'm calling you, patient is more miserable. Every 1 hour is more miserable. These are very, very important information that we need to know. Location of the symptoms. Where is it? Is it localized? Is it all over the place? Is it somewhere radiating to somewhere? That's important. Somebody has abdominal pain on the right upper side radiating to the shoulder. We know this is gallbladder inflammation. We call cholecystitis. That means it is very important to understand radiating pain is important. Patient has a back pain radiating to the leg. Means sciatica. Means the nerve involved. And that's radiation. It's extremely crucial. What makes the pain worse? Aggravating factor. Is it by touch? You do it. You're touching, it gets worse. Is it, for example, it's a vomiting, is a nausea. When the patient eats, it gets worse. When the patient took the medication, it got worse. Position is important. Position is very important. For example, somebody has shortness of breath. You lying patient flat, shortness of breath is getting worse. The first thing you think, this is heart. The minute patient is supine, it put more pressure, diaphragm area is going to high. That's why patient gets more shortness of breath. Position is very important. Bending over. Like, for example, when the patient's sitting, lying down is okay. But when I ask the patient sit up and bend over, the pain in abdominal area got worse. Pancreatitis. Pancreas has inflammation. Because the minute you bend over, you put pressure on the pancreas. The pain gets worse. What makes the pain better? That's important. Somebody has a very bad epigastric pain. Think about has a chest pain. Eating food feels better. Then you know this is not heart. This is more stomach. Okay? That makes it better. I have a patient, when lying flat, it has a lot of shortness of breath. When I elevated the head of the bed, patient feels better. That's heart. That's cardiac. That means definitely, or maybe COPD, that the patient has shortness of breath. That's why when lie flat, has wheezing, shortness of breath. When I elevated the head, feels better. What makes the symptoms better? For example, I give oxygen, the patient feels much better. I did some warm compression on the area of the pain, patient feels better. I put ice on the area of the pain, patient feels better. See, there's a lot of differential diagnosis can be different. History, very, very important part. Has this resident had the same symptoms in the past? And what did we do last time? That's very important, because that can be recurrent symptoms. And what the action we made last time is important. This kind of information is important. Sometimes patient can share with you this information. Was there any medication has been changed recently? Any abnormal lab recently? Do you have the numbers? Any new order from the recent outpatient appointment? Patient went, for example, to his oncology appointment and there's some new orders happen and we are not aware of that. Any unusual events happen today, that's very, very important. Let me tell you an example. Like 72 years old gentleman, history of hypertension, COPD/asthma, history of hyperlipidemia, which is high cholesterol, is here at a skilled nursing home for fall, hip fracture, and now is getting rehab. He uses albuterol because of asthma and COPD for shortness of breath and wheezing. He has chronic cough, and he uses the inhaler once or twice during a rehab. This evening, that his cough and shortness of breath, it just got worse than usual. Tried some albuterol with no effect. When you visit him, he's lying in bed, but not his usual. Very tired and objectively using more neck and chest wall muscle to breathe. When you check the vital sign, patient has normal temperature, means no fever, blood pressure is okay, respiratory rate is fast, O2 saturation is low in the room air, heart rate is 93. He looks tired. Before you make a phone call, it is very important to collect the information. Is there any lab recently happened and why? Ask resident that has the symptoms and episodes in the past and what were the best treatment that happened at that time. Sometimes patients are the best doctor. They can guide you to do what you need to do next. Look for the order to see if there's any PRN order for this problem. A lot of times there are PRN order. For example, there is a nebulizer order, albuterol, ipratropium nebulizer in the order as a PRN, but we don't notice that. If there's a PRN order, go ahead, start the treatment. Look and see how the patient was in the last shift. Was the patient was symptomatic? Again, we talk about onset. We talk about when the symptoms started, how does it started, and ask the patient about what it makes it worse, what it makes it better. Before some question, the physician will ask you. Physician will ask you when you talk about cough, quality, how bad it is. Productive or non-productive? Is a sputum come and not a sputum come? What if a sputum comes, what does it look like? What is the color? Physician asks you, was the shortness of breath associated with tachycardia? Why this is important? Because you may have pulmonary embolism. It may be infection, maybe pneumonia, but these are the important questions they're going to ask you. We will talk about it for every symptom. How uncomfortable is this patient with shortness of breath? Is the patient is miserable? Is the patient getting confused? Is the patient getting tired with shortness of breath? Mental status, ability to eat and drink is very important that you prepare yourself. I don't know, doctor. I don't know if the patient had eaten. Let me ask CNA. That's not appropriate assessment. No, doctor. Patient was not able to eat dinner tonight. Looks very tired. Okay? And very tired. He's alert, but very sleepy. He looks very, very exhausted. That's kind of information the doctor needs to know. Or, no, patient is absolutely okay. He's alert, is making sentence, talking to me, explaining about that he has the symptoms in the past. This is a confident nurse, okay? And then the doctor says, by the way, did you have your stethoscope? Have you able to listen to the lung? Did you hear any whizzing? Did you hear any crackers? Did you hear, when you, even without listening, when you're close to the patient, do you hear some whizzing from the upper respiratory? Have you checked the vital signs, any fever, which I told you, collecting crucial information, vital signs, CPR, status, all this stuff needs to be prepared. And the potential question is probably the doctor says, has the patient had a chest x-ray recently? You need to prepare. That's a part of the crucial information. Is there any associated symptoms? Like, for example, shortness of breath with chest pain can be cardiac attack, heart attack, can be pulmonary embolism. Has the patient has a leg pain? Do you see the pain, any swelling in the leg? Shortness of breath, tachycardia, chest pain, leg swelling, pulmonary embolism. Probably blood clot was in the leg, moving up. Any symptoms and any COPD or asthma diagnosis in the chart. That's important. That's part of the problem list that is important to understand. And how comfortable you are as a nurse to managing this patient with the COPD and a skilled nursing home. Do we have nebulizer, medication emergency kit? These are so important. Yes, we have actually albuterol, ipratropium in emergency kit in our Omnicare, Omnicell. We can easily go get it. If you just give me order, I can start nebulizer for a patient. Yes, we have a nebulizer machine. We can start the treatment, okay? If we wanted to go antibiotic, yes, I'm comfortable. I can put IV line. I can start IV antibiotic. I can give the fluid to the patient before we waiting for a chest x-ray. I will call the x-ray. I'm sure they're not going to come till morning, but we're able to treat the patient overnight and be able to monitor the patient overnight. Your sounds of confidence is everything's about the telephone encounter. The take-home points is be prepared for your phone conversation. Always be prepared. Do not just go look at the symptoms and go over the phone, or just go to your texting and just give them some information. Be prepared. Collecting the most critical information. Identify what are the clinical critical informations are and take them on. The chart digging as much as information. You don't need to go to looking at some other IDT meeting and all. No, you just need to know recent vital sign, recent change of medication, any recent labs, any recent new orders, any change of medications happened in the last 24 hours or something like that. Is there any orders came? Like, for example, patient went to appointment today or yesterday, there's some new order came. And relevant information is extremely crucial. I'd love to hear from you if you have any question, but we're going to continue based on that what we talk about, telephone encounter for assessment in each symptoms. What are the information we need to know and we need to collect from the bedside? Thank you so much.